us start with the second case. Dr. Sushma covered the first part of it. So coming to the second case, this is our 6-year-old girl presented to us with fever since 5 days, abdominal pain, loose stools, and vomiting for 2 days, lethargy and poor intake for 1 day. She had decreased urine output since morning of admission. So these were the presenting symptoms. So as Dr. Sushma mentioned, we go by the PALS guidelines, and according to the PALS guidelines, what we do is first we evaluate, we identify, and then we intervene. So on evaluation, what we found was the child was tachypneic, respiratory rate was 38 per minute, heart rate was 120, that is tachycardia, saturation were 87% in room air, peripheral pulses were weak with CRT of 4 seconds, and blood pressure was 76/40. So if you go by the age criteria, the child was definitely hypotensive and the sugars were normal, that is 75. So on initial evaluation, our impression was respiratory distress with hypotensive shock. So what is the next step? We'll have to stabilize the child. So how will you do that? First thing, it is important to position and maintain airway. And now one important thing here is this child has to be flat on the bed. Unlike, where we keep 30-degree head and elevation in respiratory diseases. Why? Because this child is in hypotensive shock. Make sure that the airway is maintained with shoulder roll so that you maintain the slight neck extension. Start oxygen by non-rebreathing mask at 12 to 15 liters per minute. Establish IV access. Collect the blood samples, especially for the cultures, blood gas, and you can have some extra samples in plain and EDTA bulb, as we discussed in the previous case. This child requires definitely a normal saline fluid bolus because the child is in definitive hypotensive shock, which is given over 10 ml per kilo over 10 minutes. After giving the fluid bolus, it doesn't end. We have to reassess and repeat the bolus if needed. That's why it is always evaluate, identify, intervene again and again, re-evaluate. Consider inotropes early because studies have shown that if you give excessive fluid bolus, it increases the morbidity and mortality. So you need to be very careful when you give the fluid boluses, and more so if there is a cardiac involvement. So consider inotropes early and start with empirical IV antibiotics, that is injection ceftriaxone, 100 mg per kg diluted in 50 ml normal saline over 30 minutes. So after initial stabilization, what is our next step? Okay, so one important information I would like to give here is that we did the rapid antigen test because the child is coming in the during COVID pandemic, and we repeated we did the rapid antigen test, which was negative. So after initial stabilization, going to the next step, that is primary assessment. Again, the PALS approach, ABCD pentagon. So this child has open and stable airway. On respiratory system examination, child was tachypneic, it was equal, no added sounds, and now the child is maintaining SATs of 90% on non-rebreathing mask. However, the hemodynamics still remain unstable. That is the heart rate 140 per minute, that is tachycardia, though the child is in sinus rhythm. The capillary refill time was more than 4 seconds. And if you look at the blood pressure, the child is still hypotensive with systolic of 78 and diastolic 35 and mean of 50 millimeters of mercury. Both central as well as the peripheral pulses were weak, and the child had cold, clammy extremities. So the child was definitely still in a state of hypotensive shock. Coming to the next step, that is disability. The child was neurologically, conscious but responding to verbal stimuli. Pupils reacting to light, normal in size, motor activity is normal, and the sugars were normal. Child was febrile, had erythematous blanching rash over the face, over the chest and the back, and there was some facial puffiness noted. So on ABCD approach and primary assessment, what is your physiological categorization? And as it is evident by the findings, the child is in definitely hypotensive shock with respiratory distress, and probably we'll come to the diagnosis after this secondary assessment. So on secondary assessment, that is sample history and focused examination, what we found was 6-year-old girl weighing 20 kilos, history of fever since 5 days, loose stools, vomiting, and abdominal pain for 2 days, lethargy and poor intake since 1 day, and decreased urine output since morning of admission. The child has rash over the body, there was redness of eyes and lips, and history of mild fever, cold and cough 1 month ago. So this is a very important history. And father had COVID 3 weeks ago. So with this significant history of COVID-like symptoms 3 to 4 weeks ago, and the typical clinical findings, we come to the systemic exam where her weight is 20 kilos. She had facial puffiness. On the respiratory system, child was still tachypneic, however, maintaining SATs 90% on NRM. There were some basal capitations coming up now on respiratory system examination. Child still remains hypotensive. Heart rate is 130 per minute. Now there is S3 gallop. Peripheral pulses are still weak, and capillary refill time is 4 seconds. So hemodynamically, child is still compromised. Child is still in state of shock. Per abdomen wise, liver was 4 centimeters, soft and tender, and leading to tenderness in the epigastric region. Bowel sounds so normal. On CNS examination, GCS was 15 by 15. Pupils were normal. There was no neurodeficits and the plantars were flexors. So what is the impression on your primary assessment and sample history, and then coming to the systemic examination? So definitely the child has cardiorespiratory system involvement. So child is in hypotensive shock and most probably cardiogenic in origin, because there is S3 gallop and liver is 4 centimeter below the costal margin, soft and tender. So there is tender hepatomegaly of congestive cardiac failure. And what you see is probably it is coming from multi-system inflammatory syndrome of children. There is definite history of contact with COVID 3 to 4 weeks ago. And why KD type? Because the child had peculiar rash, erythematous rash over the body. So with this initial finding and initial clinical presentation, child needed to shift it to ICU. Now coming to MISC, that is multi-system inflammatory syndrome of child or children. This is the WHO definition, and what it tells us is that any child who presents between 0 to 19 years of age, presents with fever lasting more than or equal to 3 days, and has any 2 of 5 of the following. So what are those 2 criteria? Rash, bilateral non-purulent conjunctivitis, or mucocutaneous inflammation signs like on the hands, feet, or on the hands, feet, or oral. Child in shock, or child has hypotension. There are features of myocardial dysfunction, pericarditis, valvulitis, or coronary abnormalities. Now this includes echo findings or elevated troponin or NT-proBNP. These are the cardiac markers basically. So if they are elevated, if they are abnormal, that again qualifies for involvement of the heart. Evidence of coagulopathy in the form of deranged PT, PTT, or elevated D-dimers. Acute GI problems like vomiting, diarrhea, abdominal pain, as this child has all these things. And elevated markers of inflammation, or other inflammatory markers like ferritin, etc. And no other obvious microbial cause of inflammation, so including bacterial sepsis, staph or streptococcal shock syndrome. And child needs to have evidence of COVID-19 infection in the form of positive RT-PCR test or serology, and likely contact with patients with COVID-19. Now, this child had history of COVID-like symptoms 4 weeks ago, and there was a definite contact with the father who had COVID-19 infection. So when you have clinical suspicion of MISC, like in this child, how will you proceed? So basically, how will you do the workup of this child? So you need to do the workup for MISC if there are typical presentation or if the child is in shock uh, with multi-organ dysfunction syndrome or KD-like features, or if the child is in has mild symptoms, then you need to look for other etiologies along with the baseline investigations. So what are those baseline investigations or the tier 1 tests? We do the CBC, CRP, ESR, LFTs, RFTs, arterial blood gas, SARS-CoV, RT-PCR or antibody. Now we need to look for other etiology as well because this is we are entering the monsoon, and as you can see that we are seeing more and more monsoon related cases. So if indicated, rule out, do the test for malaria parasites, dengue, serology, send the blood culture, urine analysis, chest x-ray, sonography, and at the same time work for leptospira and scrub typhus. If there are definite signs of MISC or the child is severely sick in the form of shock with or without multi-organ dysfunction syndrome, or child has typical features of Kawasaki disease like phenotype, then in that case, you have to go with the tier 2 workup along with tier 1 workup. So we have seen the tier 1 workup. So what is the tier 2 workup or the tier 2 test? There you do the cardiac markers in the form of ECG, echocardiography to look for the cardiac function and the coronary arteries. Do the lab cardiac markers like BNP and TROP-T. Other inflammatory markers like ferritin, fibrinogen, LDH, triglyceride, cytokine panel, and hematological parameters, coagulation parameters like PT, PTT, and D-dimers. If the child doesn't have severe MISC or the child is not severely sick, then you just do the tier 1 workup. And if it comes positive, so when we say the tier 1 workup is positive, it has to be have following two of these features like CRP more than 5 milligram, ESR more than 40, ALC of less than 1,000, platelet counts less than 1.5 lakhs, serum sodium of less than 135, neutrophilia or hypoalbuminemia. If you have two of these criteria present, then we say that the tier 1 workup is positive, and these children should be subjected to even tier 2 workup. So you need to do the tier 2 workup if your tier 1 workup is positive, or if the child has severe MISC in the form of shock with multi-organ dysfunction syndrome, or if the child presents with the KD phenotype or Kawasaki disease like picture. If the tier 1 workup negative, you need to keep in mind alternative diagnosis and continue to follow the child in the hospital preferably, and at the same time monitor for evolution of MISC. Once you have done the workup, let us unpack the MISC management. So I think MISC management basically depends upon what phenotype the child is presenting to you. So there are three clinical or distinct phenotypes we see in MISC. One is shock with or without multi-organ dysfunction syndrome. So this is a severe variety. Then we have got KD phenotype. Again, this is severe MISC. And there is mild MISC where the child doesn't have shock, no cardiac dysfunction, and no features of Kawasaki. Now let us focus on a child with MISC presenting in shock with multi-organ dysfunction syndrome. While doing that, I think the supportive care is very, very important. Any category for that matter, general therapy or general supportive care is very, very crucial because these patients are extremely sick. They need to be monitored, and you need to look after even other parameters or other features of the other factors in the management. So coming to shock with MODS, here we are proposing the combination therapy, that is IV methylprednisolone 10 to 30 milligram per kilo per day, maximum 1 gram for first 3 to 5 days and subsequently taperization. Along with IVIG 2 grams per kilo over 12 to 16 hours, and the maximum dosage is 100 gram. We have to start with empirical antimicrobials, and as we discussed, we prefer ceftriaxone. Remember that if child responds to your fluid therapy on day 1 leading to resolution of shock, then please decrease IV methylprednisolone to 2 milligram per kilo per day and for next 3 to 5 days and subsequently taper it off. If there is a treatment failure, now the treatment failure has been defined as if there is a persistent fever or ongoing significant end organ dysfunction after 40 to 72 hours of treatment, or there is a recurrence of fever within 7 days, then you consider this as a treatment failure and take expert or pediatric rheumatologist opinion for the biologics. We'll come to the biologics later. Now coming to the KD phenotype. For KD phenotype, IVIG remains the drug of choice, and there we give IVIG 2 gram per kilo over 12 to 16 hours, that is maximum dose of 100 gram, and IV methylprednisolone, that is on the lower dose, that is 1 to 2 milligram per kilo per day for 3 to 5 days, then taper. Remember that sometimes IVIG 2 gram per kilo, the amount of fluid the baby receives, if the child is weighing heavily, then it can lead to fluid overload. So you can increase the duration, or sometimes we even give the dosage over 2 days, 1 gram per kilo on day 1 and on day 2 again 1 gram per kilo. So I think you need to be very, very careful when you are giving IVIG, especially large doses. If IVIG is not available, so it applies to both shock, MODS, or even KD phenotype, then IV methylprednisolone 10 to 30 milligram per kilo, maximum of 1 gram, after the parental consent should be considered. We discussed about IVIG in patients with cardiac failure and fluid overload. Treatment failure we looked at. When it comes to biological, I think treatment failure is quite uncommon, and in our practice at SRCC, we have not seen treatment failure in patients so far treated. But in case there is treatment failure, you can consider other biologics like anakinra, tocilizumab, or infliximab in such situations. But remember that before you use this, seek the expert opinion. Now coming to the milder variety where there is fever and other non-specific signs and symptoms, and the child doesn't have any signs of shock or cardiac dysfunction or KD phenotype. In that case, this child requires intense or careful clinical as well as laboratory monitoring in the hospital setup. One should do the investigations as needed and always look for the alternative diagnosis. If there is worsening of a child in the hospital, then definitely treat according to which, if there is evolution of MISC and the child develops KD or shock MODS type, treat the child accordingly. If no worsening, but at the same time there is no improvement, then you may consider even IV methylprednisolone 1 to 2 milligram per kilo per day for 3 to 5 days and see the response. But if there is no response and the treatment failure as we discussed, then definitely again look for the alternative diagnosis and try to rule out. Now this slide is taken for the IAP guidelines. Some more information on management. Again, as Dr. Sushma said, this is the Gantt slide. See, MISC is a diagnosis of exclusion. So you need to exclude other possible diagnoses before you come to that. And MISC should be made strictly as per WHO definition. Other causes of inflammation and infection has to be excluded. As we are seeing that, there are recent studies have shown that there is increased seropositivity in children to the tune of 50%. So as many children are seropositive in the current epidemiology, we as clinician has to be very, very careful to avoid overdiagnosis. I know that we don't want to miss the diagnosis, but at the same time, with current epidemiological evidence and at the same time, the monsoon-related diseases coming up, avoid both under as well as overdiagnosis. Stop antimicrobials once cultures are sterile and sepsis is reasonably ruled out. repeat lab investigations, ECG, echo as per the need. I think we'll come to that, how to follow up these children laboratory wise. Coming to steroid therapy, once you are given the bolus steroid therapy in MODS, shock, or KD type that picture, then switch to oral prednisolone, 1 to 2 milligram per kilo per day after 3 to 5 days of initial therapy, and then taper over next 2 to 3 weeks. This is very, very important. We have to taper the dosage over next 2 to 3 weeks. All the children, all the patients with MISC, including mild, we have to start them on low dose aspirin, that is 3 to 5 milligram per kilo, maximum 75 milligram per day for at least 4 to 6 weeks. And this therapy sometimes has to be given for longer duration if there are persistent coronary artery dilatation or abnormalities. However, the low dose aspirin or the aspirin therapy is contraindicated if the child is bleeding or the platelet counts are less than 80,000. Is there a role of therapeutic low molecular weight heparin? Yes, there is. If the child has evidence of acute thrombosis, there is moderate to severe ventricular dysfunction. When I say moderate to severe, your left ventricular ejection fraction has to be less than 35%. If the child has evidence of coronary dilatation or aneurysm with Z scores of more than 10, so it basically aneurysm. And if you find this, high risk factors, then definitely the child should receive low molecular weight heparin in the dose of 1 milligram per kilo subcutaneously twice daily if child is more than 2 months old, or if it is less than 2 months, then we give slightly higher dose, that is 1.5 milligram per kilo subcutaneous. Follow-up cardiac evaluation, that is echo, should be done at 2 weeks and 6 weeks and as per needed after the discharge. I think it's very, very important because the coronary abnormalities, they persist for longer duration, and as long as they're present, I think we should look for the complications associated with that. And your aspirin therapy has to be continued. So coming to our child, who has hypotensive shock with respiratory distress and probably MISC of KD type. So when we investigated the child, as you can see, the child had significant lymphopenia, the BUN and serum creatinine both were elevated. His inflammatory markers were elevated as well, IL-6, CRP, ESR, serum ferritin, all were elevated. And even his cardiac markers like NT-proBNP and troponin both were elevated. His D-dimers were in 5,000s. When we looked at the COVID antibodies were positive and the PCR was negative. If you look at the X-ray, what you see here is in basically pulmonary edema, pulmonary congestion. He alternative tried to rule out, malaria, dengue, and all those other tests were negative. On 2D echo, we got significant findings. There was mild LV dysfunction with ejection fraction of around 35%. If you look at the cross-sectional view, what you see that there is a thin rim of pericardial effusion, and there were coronary artery abnormalities. As you can see, the left main was dilated 3.7 millimeters, left anterior descending was 3.4, and right coronary artery was 3.7 millimeters. All the Z scores were more than 2.5, and that is a significant dilatation or abnormality. So now we have confirmed, looking at the clinical features, looking at the lab investigations and the 2D echo findings. So this child has multisystem inflammatory syndrome of children, and it's a KD with shock phenotype. Now, as the name implies, the multisystem inflammatory syndrome in children has multi-organ involvement, that is head to toe. If you see, the child has symptoms of fever, but prolonged fever that more than 3 to 4 days. There is significant myalgia. We have got mucocutaneous features like conjunctivitis, rash, lymphadenopathy, stomatitis. You can see the edema of the limbs. Child will have headache, lethargy, sometimes signs of meningeal irritation. Cardiac wise, we already discussed, child can have myocarditis, hypotension, shock, coronary artery and abnormalities on 2D echo, and elevated cardiac markers like troponin and proBNP. Respiratory symptoms of hypoxemia, respiratory distress. You can see the pulmonary infiltrates on the X-ray. Majority of the patients, like what we have seen in the last 1.5 years, majority of MIC patients, they present with nausea, vomiting, abdominal pain, and diarrhea with elevated liver enzymes. Okay, hematological picture of thrombocytopenia, neutropenia, lymphopenia, as we discussed, and many children can have acute kidney injury in the form of hyponatremia, oliguria, or anuria. See, they have many of them, as we discussed, they have inflammatory markers, and there is lab evidence of current or past infection with SARS-CoV. If there is no evidence of infection, at least there will be a history of significant contact with the COVID-19 patient. Now, coming back to our case, so that the child has hypotensive shock, cardiac origin, MISC, due to MISC KD type. So this child was intubated and ventilated because the child was in shock. And we discussed about lung protective ventilation, which is very, very important. Low tidal volume ventilation, that is 46 per kilo. You need to restrict your mean airway pressure less than 28. Accept the pH of 7.15 to 7.25 as long as you are, CO2s between 50 to 60, that is permissive hypercapnia. And make sure that, you prone these children if you can, that is very, very important as a part of the lung protective ventilation. The child requires central venous as well as arterial line insertion for the monitoring and sampling and arterial blood pressure monitoring. As discussed, we put the child on 80% maintenance IV fluids after initial resuscitation. She required inotropes in the form of adrenaline, maximum 0.07 mics per kilo per minute and bilirubin of 0.5 mics per kilo per minute to stabilize her hemodynamics. We gave IVIG 2 gram per kilo, single dose over 18 hours. IV methylprednisolone as well, 500 mg per day for first 5 days. We started on low molecular weight heparin because in view of the significant, there are coronary abnormalities, LV dysfunction, and D-dimers were high. So 20 mg subcutaneous PD. Now, while doing giving this intensive treatment, I think intensive monitoring is also required, and has to be clinical as well as laboratory. So in the clinical monitoring, basically it is a targeted, the goal-oriented monitoring, like how the child is responding to your therapy. So whether there is improvement in the GCS, alertness, whether the child is maintaining the euthermic now, the heart rate there's return to normal or baseline for age, the blood pressure, the map is normal for age, the saturations are 90 to 94%. Don't aim for higher saturations, because if you try to do that, you're going to do more harm by aggressive ventilation. So you need to have the modest targets of 90 to 94 saturations. Aim for normal capillary fill times. The extremities has to be warm. Your peripheral pulses has to be normal, and there has to be improvement in the urine output. So these are the targets which we are looking at when we are treating the child of MIS in the ICU. While doing that, the close laboratory monitoring is essential. So you need to do the ABG 6 hourly, at least for the first 24 hours, and maybe later once a day or as indicated. Serum electrode has to be monitored 12 hourly in the first 24 hours, again then once a day or as per clinical condition. Inflammatory markers we should do on day 1, day 3, and day 7 and before discharge. Coagulation profile and biochemical profile again should be monitored on day 1, day 3, day 7 and as per indicated. Now, this next table gives you the summary of laboratory monitoring. I think this is what we discussed: how we monitor CBC, CRP, blood gases, electrolytes, inflammatory markers, and coagulation profile. I'm focusing on cardiac profile and 2D echo. So these children require repeat cardiac evaluation in the form of cardiac markers and 2D echo on day 1, day 3, day 7 if possible, or as indicated, and of course before discharge. If the child is on ventilator, these children require chest X-ray or periodically, definitely on day 1 and day 2, and subsequently as indicated. So this is a summary of laboratory monitoring. So in short, the child who presents with MISC, especially severe type, shock with MODS or Kawasaki disease phenotype, they require intensive care treatment, and they require close monitoring in the form of clinical as well as laboratory. I think with this I will stop my presentation. If there are any questions, we can take at the end of the session.